My name's Dr. Charles Chambers. I direct the cath lab at Penn State Hershey. I'm vice president for the Society of Cardiac Angiography and Intervention. It's my pleasure to be here this morning with Dr. Brar. He's going to present his work on a very important topic to interventional cardiologists. Dr. Brar?
Hi. Well, thank you for having me here at SCAI. I'm from Kaiser Permanente, an assistant clinical professor at UCLA. And it's wonderful to be able to present the 6-month clinical outcomes from the POSEIDON trial here at the SCAI meeting.
Very good. Could you tell us a little bit more about the trial?
Sure. This is a hemodynamic guided therapy for prevention of contrast nephropathy. There has never been really a trial in the past that has used any hemodynamic parameter to guide hydration peri-procedurally for the prevention of contrast nephropathy. It's interesting because it's something that we use in other clinical care settings, yet we really haven't adopted it in this way in the cath lab. For example, we use hemodynamic guided therapy in the ICU and the CCU. We even use it when the volume status is not clear to understand whether we should administer fluid or administer diuretics or just keep the status quo. So this takes that conceptual approach into the cath lab and says, well, we make these hemodynamic measurements routinely, one of which is we place a catheter into the left ventricle, we measure the LV-EDP, and this allows us to kind of get a good estimate of the patient's volume status. So the hypothesis is, can we take that LV-EDP value, use that value, and then use that to guide the extent of hydration that a patient administers? And so if the LV-EDP is low, that patient probably is a good candidate for getting additional amount of fluid. And if the LV-EDP is high, that patient may benefit from fluid, but one may need to be more modest in terms of how it's administered. So the POSEIDON trial tested this personalized hydration protocol. We call it kind of the sliding scale of hydration because it parallels kind of administration of insulin in some ways. The lower the EDP, the more the fluid, the higher the EDP, the less the fluid. And we tested this hypothesis in a randomized controlled trial.
All had some component of prehydration in both groups, is that correct?
So all patients were hydrated for the same period of time, 1 hour before the procedure, 4 hours afterwards. So that is, I think, also a practical duration of hydration that one would be able to then adopt into
totally
our day-to-day practice.
Right.
So everybody gets the same period of hydration. What differs is the hydration based upon the LV-EDP. So the patients all get a bolus before they go into the cath lab. And in the cath lab, the first measurement the operator makes is of the LV-EDP. And then based upon that value and based upon the randomization, either the patient's hydrated according to the LV-EDP hydration protocol or they're in the standard hydration group.
And you got some very encouraging results.
We did, and so we previously reported the CIN results, and with the LV-EDP guided hydration, there's a roughly 60% reduction in the rate of contrast nephropathy, and quite remarkable because we're administering normal saline, and we're using a hemodynamic parameter we're used to, and so the implementation is very straightforward in terms of adopting the protocol. But here at the meeting, I think we're reporting even something more interesting, and that's the 6-month clinical outcomes. It's really wonderful that hydration prevents the contrast nephropathy rates, but I think a critical issue is how does this impact hard clinical events? Does it have an impact on death, myocardial infarction, need for dialysis? And this has kind of largely been a neglected area in the clinical trial literature, especially in the contrast nephropathy trials. And so here we're showing for the first time the 6-month clinical outcomes, and these show a very profound reduction in the composite major adverse event rate, which is death, myocardial infarction, and stent thrombosis with this hydration strategy. 68% reduction and a highly statistically significant p-value associated with that.
Was that surprising to you in the population you were dealing with? I mean, they weren't as sick as some of the populations that have been looked at in the past with contrast-induced nephropathy.
Yeah, and so I think one of the things is these patients tend to probably be at higher risk of future events than we recognize.
Good.
They all have stage CKD stage 3 or greater. But in addition to that, if you look at the demographics, on average, they're 70 years of age, 50% of the patients have diabetes, and so CKD carries with it a lot of comorbidities that make these patients at higher risk. And when renal function deteriorates further, these patients are at even higher risk of recurrent events, and important recurrent events, death, again, heart attack, and the need for dialysis.
Yeah, and I was surprised in outcome, as you said, death was...
And death was, as was myocardial infarction, they both independently in terms of the components of that composite endpoint, both death and myocardial infarction, both reached statistical significance. There was a lower rate for dialysis, for myocardial infarction, and for mortality with hydration.
Now, has that impacted practice? How would you think that would impact practice? I think a fair number of angiographers don't do the LV gram first, don't get LV-EDP first. Do you think this is a reason, particularly in this high-risk population, to encourage that approach?
I think so, and I think having that information going further into the procedure probably helps the operator as well in terms of understanding where they're starting with the EDP. That may impact, obviously the fluid administration, but it may have other impacts in terms of, understanding the safety issues related to the procedure. If you got a low EDP and patients complaining a little short of breath, you may not be too concerned about it if everything is going well. If you started with a really high EDP, then you know that your threshold in terms of patient getting into trouble might be lower. And so I think the value may be helpful during the PCI as well. But I think that the greatest benefit is by altering the workflow, you can get a very tremendous reduction in the rate of contrast nephropathy. But now we also know long-term clinical events as well. So to implement the protocol, you do have to change your workflow a bit. You do need to get the pigtail catheter into the ventricle, make the LV-EDP assessment before any contrast is administered, and then have the nurse adjust the fluid rate at the start of the procedure and then keep that going for the duration of